Hello friends, my name is Dr. Saif and today we are going to talk about the geriatric patients in ICU. So in intensive care unit, every heartbeat counts for us. But when the patient is elderly, that is age more than 65 years, each decision echoes far beyond the monitor, far beyond the walls of cubicle where the patient is residing. Welcome to the challenging world of geriatric critical care. And as you know, these patients account for a significant proportion of intensive care unit admissions. About 20 to 25% of these patients can be in ICU, and it is increasing. And even the mortality rate in such kind of patients also, however, varies, but it is as high as up to 37%. So it is somewhere between the 15% to 30%, okay, 37%, up to 37%, the maximum which is reported. Now, the elderly patients are not just the older version of the young patients. They bring with them the decades of wear and tear, the loss of physiological reserve, and often the frailty. They are very frail. They are weak patients, very sensitive to any minor insult which can tip the balance. As everybody, all the organs are in certain harmony, certain balance, and when you age, these balances are getting weaker and weaker, and anytime any small insult can tip this balance. And our interventions, especially in ICU, the invasive interventions are not always as predictable. So the response to our therapeutic intervention is not as great as we see in younger population. So most geriatric ICU patients arrive to ICU or emergency department with a long list of medications. Some help, some harm, and many of these medications interact with our ICU medications. Adjusting the doses of these medications and watching for the renal clearance and hepatic clearance and minimizing the side effects is delicate dance for each intensivist. So that is the reason we need more and more geriatric intensivists supported by the team, by a team of pharmacologists, physiotherapists, etc., etc. And remember, the textbook do not apply here. An infection or sepsis might show no fever, no tachycardia, no hyperventilation, sometimes no shock even. A myocardial infarction might come with nothing more than a fatigue. And recognizing these quiet alarms is critical, is very, very challenging also. For example, delirium. It is not just a confusion, it is the predictor of worse outcomes in elderly patients. So you have to be very, very serious about the delirium. Similarly, pre-existing dementia, sensory deficits, and hospital stressors all contribute to the outcome of such patients. Again, managing the sedation while the patient is on mechanical ventilation is very challenging because you need to maintain the orientation of these patients and prevent the delirium in such patients. It is an art. So you need to be very, very artistic in managing the sedation while maintaining the orientation. When do we push forward and when do we pause? This is a decision which we have to make about mechanical ventilation, resuscitation, and life support. All should be rooted in the patient's values. This requires compassion, communication, and courage, both from the doctors and medical staff side and from the patient's family. In the ICU, our job isn't just to keep the patient's heartbeat going or the ventilation going on. It is to honor the lives lived. Managing geriatric ICU patients demands more than knowledge. It demands empathy, adaptability, and respect for what truly matters. So, as you step onto the ICU floor, remember it is not just about medicine, it is about the meaning of life or value of life. So, that's all for today. Thank you so much for your attention. And remember your geriatric patient in ICU and value them. Bye-bye.